شكرا. Thank you very much for the kind introduction. Ladies and gentlemen, good afternoon. I'm just getting myself ready. I think you already know about me, so I can skip that slide and go to the next slide. Okay. The topic of my presentation today is going to be about my top 10 use cases for AI. And this is based on my own personal experience. I've been using AI for the past maybe 6 or 7 years. And I've often been asked what my preference is. And I cannot really pinpoint a single application, but I can definitely mention 10. And here I have my top 10 cases. And I'm only using this as an introduction to what your top 10 cases can be. So let's kick off with my disclosure and affiliations, and I assure you none of them conflicts with the nature of this conference. My agenda is very basic. I'll start with a brief introduction on why we need AI in imaging, and then I will go through my top 10 use cases, and then explore your top or potential top 10 use cases, and I'll wrap up. I've got 25 minutes. I've already consumed 2. Why do we need AI in imaging? You've probably seen slides similar to this where the workload for radiology is increasing while the numbers of radiologists are not, and there is that gap that needs to be bridged between the supply and the demand. And that gap is created by the increasing workloads with the workforce. And not only the workforce, but the expertise of radiologists is dwindling, and the reduction in reimbursement for radiology work. And what this does, it creates backlogs. With that come higher error rates and staff burnout, a subject that we're all very familiar with. How do you bridge the gap? Well, it's impossible to actually fill it without AI. Because you cannot increase the number of radiologists overnight. You cannot reduce the workflow. So AI seems to be the only way forward. What does AI do for us? Basically, it allows us to increase efficiency and quality in imaging as it does in healthcare. And this is the most basic of definitions for both efficiency and quality. And with efficiency and quality, the outcomes of healthcare become way better. So in radiology, how do you improve on efficiency? Through workflow enhancements, through automations, improvement in reconstructions, but also efficiency and quality. Both of them can be improved through quantification abilities, decision support systems, and clinical record improvements. I will show some examples in my top 10 use cases that work in this area. But this is a very simple workflow for radiology, whereby AI can be introduced in the pre-image stage, which is the acquisition and pre-processing of imaging, or in the reading stage, which is the interpretation of the images, or the tasks related to the images, and to the post-reading stage. So these are the 3 main stages of any radiology workflow. Now, the first one of my use cases is targeting the holy grail of radiology, which is reduction of radiation dose. If you can reduce radiation dose, you would, number one, reduce harm to your patient. But you are also reducing utilization of your equipment. Because of that reduced load on your equipment, you're reducing the number of tubes that need to be changed. You're exhausting your machines way less. So there is huge saving to be made for your department. But on the downside, you reduce your radiation dose, and what do you get? You get lousy images, like the one on the left. It's noisy, and you would be very brave to interpret this image. Why? Because of the quantum noise. Not enough X-rays are reaching, and there's a lot of noise. By using denoising algorithms, you can actually improve that image and bring it up to what it should be had you used standard image. The image on the left actually used 60% less radiation dose, but you were able to bring it up to normal levels by using denoising applications. So that's an example of radiation dose reduction. That's another example. Again, that's a CT of the lung, virtually useless image, and that's an ultra-low dose of the chest. 20% of the radiation dose was used, but if you're using an AI algorithm, you can bring it up to normal reading levels. Another example of the brain, no one would doubt that the image on the left is very grainy, and you would not really want to read images such as this all day. But by using AI algorithms, you can bring it up to standard level of readability. Number two is the holy grail of MR imaging, which is the time. You want to reduce the time your patient spends on that MR. Definitely way more comfortable for your patient. Less movement means less repeats, but also it opens up slots for extra patients. So there is money to be made there. Look at this image of the brain. Standard of care scan taking about 30 minutes, give you that beautiful image on the left. Then you feel brave enough to reduce the time by 50%, and you get that ugly image in the middle. Use your AI algorithm, and it comes back to life. 50% time saved. Another example, MR of the cervical spine, standard T2 protocol, and slashing the time by 50%, you have that noisy image. However, after using AI, you've got a beautiful image back, but having saved 50%. But how about not even scanning the patient altogether? This is an acquired STIR image from a diffusion-weighted image and a T1 image. It's actually a generated image. The patient had to spend 0 time on the scanner to actually generate that synthetic STIR from other sequences. So you're generating a sequence that wasn't even acquired. That's 0 time. Think of that. Even advanced time of flight, 3D time of flight images, this in a conventional scan takes about 7 minutes, but we had the guts to do it in 3 minutes and then doctor that image to bring it up to the levels that I believe are even better than the original image. Why is it better when it's using less time? Because you're denoising your image. So you're removing some of the noise that was inherently present in a standard protocol. Number 3, contrast media. No one likes contrast media. Radiologists don't, patients don't, administration don't like paying for them. So how about reducing the amount of contrast media? This is a research image where 1/10 of the contrast media was administered, and that lesion in the brain is virtually unenhanced. We know it took some enhancement, but it's just not visible. However, when you enhance the image using AI, the image lights up 10%. The commercially available products like this one allow you to slash the amount of contrast medium by 50%. A lot of saving when it comes to finance, but also way more convenient for your patient and way less chance of allergic reactions. 50% reduction. So you start with the low dose, you get some kind of enhancement, it's not really that good. However, you apply your AI solution to the same image, and these enhancements show up way clearly on the right side. Same image, but only with AI enhancement using 50% of the dose. My number This should be my number 4, actually. ER, bone and chest x-rays, emergency room, bone and chest. These are 2 applications in one. Fractures like this do not really need AI. Anyone can diagnose them. But is this an accessory bone, sesamoid bone fracture? AI actually pointed out that it was a fracture. CT confirmed it's a fracture. I think, for me, it looks very much like an accessory bone. Another fracture of the scaphoid, very easy to miss, but not for AI. What about the chest? You really need to look hard to pick up that pneumothorax. For AI, it was straightforward. I could see that image 100 times. I will probably skip it. So in an emergency room, and for those who did the residency in an emergency room, you know how hectic it is and how easy it is to miss pathology, especially that no trained radiologists are available most of the time. And these cases need to wait till next day to be diagnosed when the patient's condition has deteriorated, or he might have even passed away. Number 5, automatic measurements. We have about 150 musculoskeletal measurements. How many do we memorize as radiologists? I would say 2, 3. Maybe the calcaneal incline for flat feet, maybe the cup angle. That's pretty much it. But orthopedic surgeons are asking for way more. How about an application that actually knows all these measurements, measures them for you automatically and consistently? So when that patient comes for follow-up, it's the same landmarks that are being used. So you can follow up consistently. And you're saving a lot of time in using that system rather than looking up for how to measure these landmarks. How about an automatic system that interprets your MR of the spine for you? There are several systems in the market. Most of them work very well, and they give you more than bargain for. It labels your spine, it gives you vertebral heights, it gives you the discal herniations, it gives you the numbers and the percentage of herniations, and it compiles your report for you. It even populates your report. So that's an application that I feel is quite useful, since a lot of our musculoskeletal MRIs are for the spine. Chronical CTA, we have the expert on coronary CT. We have Professor Dia with us, and I was quite impressed by both his lectures. And Dia, this might look very modest compared to what you've shown, but remember that I'm more of a generalist than a specialist. So what coronary CTA has introduced is the ability to provide amazing 2D images, 3D images, animated images, extraction, line extractions, identification of stenosis. That's all anatomy, and quantification of pathology. But it went beyond anatomy. AI allows for a couple of things that are in the domain of histology and physiology. Now you can actually not only identify plaques, but actually get to know the composition of these plaques. Why? It's so important to know the composition, because some plaques are better left alone, the stable ones. Others you need to intervene, and you need to know, is it fatty, is it fibrofatty, is it calcific? You really need to know where are the vulnerable plaques are and how vulnerable they are for you to intervene. I think it's even more important than stenosis measurement, and AI does that for you automatically. How about FFR, functional flow reserve? There's a lot of buzz about FFR. So what's the rage? The rage is when you're doing CT angiography, a lot of the cases fall in the gray zone, the 50 to 60% stenosis, and you really don't know what to do. Are you going to intervene and put a stent? Are you going to ask that patient to come again? You really don't know, because you do not know what the downstream flow is like. And this is really the deciding factor for if you're going to go for a stent. If you've got less than 80% flowing distally past the stenosis, you need to stent. If it's actually more than 80%, you do not need to do anything. But for that, you need FFR. How do you do FFR? Traditionally, we used a wire, a pressure wire to measure the fractional flow reserve. So you need that caster, you need the wire with the expenses associated, but it's not just the expenses, it's the expertise on using the wire. Now, with pretty much non-invasive procedures such as ETA, you can generate three-dimensional images with FFR measurement in every coronary vessel, not just the suspected vessels. And this is invaluable. But you could take it one step further. You can simulate stent placement. But that simulation is valuable because it would show you the best stent for that stenosis, because it will show you the change in the fractional flow even before you touch your patient. So you could design your procedure. Are you going to use a long stent or maybe a short and wide stent, maybe two stents in a row? You can design all that virtually before you embark on deploying your stent in that patient. That is invaluable. Coming to number 8, which I believe is important to be bundled with every application you have. That's an application for prioritization. And the way it works is with the patient still on the scanner, the AI would recognize whether you're dealing with a stat case, with an emergency case, and it would move that case in your reading work list to the top of the work list, and it would notify the radiologist to cater immediately for that case. Now, for our dentist friends, and we have a dentist with us today, and we definitely have not forgotten, even though we are medical radiologists, but we work very closely with dentists, and there are dental radiologists who are even more enthusiastic than we are when it comes to advanced applications. Now, traditionally, OPG or panoramic X-rays might not be dealt with altogether in our imaging facilities, or if they are taken in our imaging facility, I do not think any of us would care to report it. As important as it is, but this is what's happening. Now we have AI solutions that actually generate reports for your panoramic images. But not only for your panoramic images, but for your cone beam CT. And in addition to reporting and diagnosing the images, they segment the dental cone beam CTs so beautifully to allow for accurate surgical planning, maybe for extraction of impacted teeth, or maybe for, more importantly, implant placements. So that's for dental imaging. Number 10, which encompasses a few applications, this is screening. We now have to deal with an aging population, but it's not just aging. It's aging, and it's more knowledgeable and more obsessed with their health. And they know the value of screening, and they come to us to help them, and we need to be ready. And of course, I think the number one screening tool, and that was the very first tool that had some form of intelligence introduced in its diagnosis, is mammography, with the CAD systems coming to the market in 1992. Very primitive CAD systems for detection of microcalcifications, yet they're considered intelligent systems. Now, for mammography, there is a classic breast cancer screening, but there is a screening also for breast density. But let's look at the classic breast cancer screening, where the abnormality is detected, it's characterized, it's scored on a classification system from 1 to 10, and an action is actually recommended. In that case, recalling the patient. Why do you recall that patient? You recall that patient because you're going to biopsy that patient. So the system really takes you through the whole work flow of managing a breast cancer case. The number two is screening. Application that I definitely recommend is the lung cancer screening. Lung cancer screening is even worse. Lung cancer is even worse than breast cancer, but there's not so much attention being paid to it. Lung cancer screening, the problem was there was no easy imaging modality that allowed for accurate lung cancer screening till the introduction of low-dose CT. Now with low-dose CT, we know we can successfully screen for lung cancer. Problem is there are so many nodules in a smoker's lung. Which ones are abnormal? Which ones are suspicious? That was purely left to a radiologist's decision, which was mostly biased. However, with the introduction of AI systems, this has been largely negated, and now we have systems that would pick up the suspicious nodules and populate a lung RADS report for that lung cancer screening. Third screening is the prostate cancer screening, which is based on MRI, and this is gaining a lot of popularity, and I think this is going to gain a lot of traction in the very near future. And definitely, especially with the downfall of PSA, this is going to be very popular. The third is the bone density, which is really an opportunistic screening. Since we do a lot of abdominal and pelvic CTs, we might just as well get an idea about the nature of the bone. And we do that, and then this is mapped to a DEXA scan report, because the T-scores are really the gold standard, but these results are mapped to T-scores. And the fifth and last is the coronary artery screening, again an opportunistic screening from low-dose CT. And with that, you can actually divide or categorize your patients into low and high risk groups for myocardial instance. The one more, or as Bill Gates would say, one more thing, application that I would add here is generative AI reporting, and I did touch on that yesterday in my lecture on reporting. And I want you to remember that radiology reports are the most important product that we generate. So this is really our final package sent back to our patients and physicians. And with that, we can, what happens, you just speak your report and it generates the spoken word in templates. Now your top 10, how do you pick your top 10? You need to internally validate what you need. It needs to be tailored to your workflow. You need to educate the users, and you need to continuously report whatever you deploy, and you need to take into consideration the ethical aspects and the social implications. And these are 3 papers I advise you to go through before embarking on deploying AI. The first one is the ECLAIR, which is the evaluating commercial AI solutions in radiology. The second one is the RADAR, and this is the radiology AI and assessment rubric. And the third one is challenges associated with deployment. And the number one is resistance to change, and I know that you're all familiar with that, and you can all relate to that. But there's also the generalization, the clinical validation issue. There's the integration into the clinical practice and the disruption it brings. There's the data privacy and security. And then there are all these regulatory and ethical considerations that my colleagues talked about. And most importantly, the cost and reimbursement, which is still very unclear. To wrap up, AI has profoundly impacted imaging, enhancing the diagnostic accuracy and speeding imaging analysis, as well as providing deeper insights into patients' health. It allows for workflow optimization, image analysis, quantification of imaging, reduction of errors, integration with HR, and also it takes into consideration the education, research, and development aspects of AI. With that, I've come to the end of my talk. Thank you very much. Thank you for not cutting me in.